So I'm going to talk to you today about neuro-ophthalmology. This is again a very important topic and quite complex in its own way. So I'm going to try and make it simple. I'm going to cover only a few common conditions relevant to your practice, also relevant to the examination, as some of these topics will be definitely asked of you in both the theory, and you could get this in the practice. So today I'm going to talk to you about motor neuron disease. It's a condition that's seen fairly commonly now because of improved knowledge about the condition, as well as the improvement in the electrodiagnostic techniques. It's a group of neurological disorders that affect the motor neurons of the anterior horn cell, and these are the outflow for the motor system from the spinal cord, and control voluntary motor activity, which includes outflow to the cranial nerves, subserving motor function, and can involve speaking, breathing, swallowing, and generalize through the body where the motor system is involved. Now, the motor system starts in the motor cortex. It passes through the brain, skirting the in the internal capsule, through the brain stem, and then through the spinal cord, finally to the anterior horn cell, and the motor system outflows from there. It encompasses the upper motor and lower motor neuron involvement. So you can have the primary form of MND, which is seen most commonly, that is amyotrophic lateral sclerosis. You can also have a pure low motor neuron type of motor neuron disease, which is called progressive bulbar palsy, we can also included in this low motor neuron type of syndrome is the post-polio syndrome and the spinal muscle atrophy. And then you can have a pure upper motor neuron type of picture in primary lateral sclerosis and hereditary spastic paralysis or paraplegia. But we'll talk mostly about the amyotrophic lateral sclerosis, since that's the commonest form of motor neuron disease that one would encounter clinically. It's a common form of motor neuron disease. There's a slight male preponderance, almost 2:1. The incidence of ALS increases with each decade, and it's most common between 50 and 70 years. The only risk factors being a family history of the same and age. There's an increased risk of developing ALS has been suggested by laborers engaged in agricultural work, manual work, soldiers, sportsmen, but at the moment this is a clinical hypothesis and still under research. Where do we suspect ALS? In a patient presenting to us where there's asymmetric distal weakness, there's wrist reflexes in a wasted limb, indicating a combination of upper motor and lower motor neuron signs, absence of major sensory symptoms, a relentless progression of symptoms and signs with involvement of especially the bulbar muscles, speaking, swallowing, and subsequently breathing being affected. So, as mentioned, the onset's between 50 and 70 years. It's a progressive weakness, wasting, fasciculation, stiffness, and wrist reflexes would be some of the clinical features. A patient presents with diverse symptoms, and therefore a high index of suspicion is needed to suspect this condition. As the disease progresses, they develop emotional lability, and also cognitive changes have been noted. There's an association of almost 50% with frontotemporal dementia. The clinical hallmark is of upper motor and lower motor neuron signs. And the upper motor neuron signs are hyperreflexia, spasticity, and extensor plantar response, that's the upgoing toes, and a positive jaw jerk. The lower motor neuron signs include weakness, muscle atrophy or wasting, cramps, and fasciculations. Now, asymmetric limb involvement is the most common presentation, but it does become symmetrical fairly soon. Bulbous symptoms manifest as dysarthria and dysphagia, and of course they can have respiratory muscle involvement, axial muscle weakness, and weight loss. The upper motor neuron extremity weakness, the upper extremity weakness is most often heralded by hand weakness, and then it can also sometimes involve only the shoulder girdle muscles when lifting objects and placing them, say, on a shelf is one of the symptoms they may have. The patient with hand weakness may complain that they lose dexterity, they start dropping things, they find it difficult to do up buttons, typing, moving a zipper. The sensations are never affected, and bladder function is impaired. Patients with shoulder weakness may report difficulty, as mentioned, of soaping the back of their head, combing their hair, and lifting things on a shelf. Bulbar involvement starts with dysarthria, which is a slurred speech and, of course, difficulty in swallowing. If a patient comes complaining of difficulty in swallowing, but the speech is not affected, then one would think of a primary pathology in the GI system rather than neurological involvement, as these come fairly simultaneously. Then, of course, they start developing shortness of breath and disturbed sleep as they lie flat. They find it difficult to breathe. Of course, the life-threatening aspects are neuromuscular respiratory failure and dysphagia, and the median survival from the time of diagnosis is between 3 to 5 years, but some people can have a very accelerated course and can, in fact, come to the end of their lives in less than a year's time. A very small percentage seem to live longer. At the moment, we do not know why this happens, but people have survived up to 10 years with this condition as well. In initiation of positive pressure ventilation can prolong survival, and lots of aids are available now to give people non-invasive ventilation at home. 5 to 10% of patients choose tracheostomy and permanent ventilation when respiratory compromise becomes severe. There are differentials to consider, and it is a serious diagnosis. So before we offer this diagnosis to patients, it's extremely important to be very sure. There are especially cervical myeloradiculopathies due to cervical spondylosis would be the main condition that needs to be excluded, but strokes, MS, spinal cord lesions, particularly a myelopathy, neuronopathy, which is basically involvement of the nerves coming out of the spinal cord, vascular pseudobulbar palsy, again secondary to stroke, HIV, B12 deficiency, all conditions that need exclusion. Also, there is a syndrome called benign fasciculation syndrome, where people develop fasciculations. It's a cause of great worry and cause of frequent referrals to neurology. But after evaluation, if there is no wasting and weakness with fasciculations, they can be benign. Fasciculations can also be caused by an excess of caffeine and stress. For cervical spondylosis, generally patients will present with neck pain. There will be some sensory symptoms. There will be no fasciculations in the tongue or the legs, as it will be generally a radiculopathy, which will cause the lower motor neuron symptoms in the distribution of the root. There can be a concomitant neuropathy can be present with upper motor, lower motor neuron picture. If the spinal cord is involved with a root involvement, then they can have wrist reflexes and upgoing planters and localized wasting, but it will be in the distribution of the nerve root affected. A nerve conduction study and MRI would help to by the picture. So coming back to motor neuron disease, there's rapid progression. It becomes symmetrical. There's bulbar and respiratory involvement, and they would need help with the activities of daily living. Just a few words about a couple of conditions that may present to the clinicians. One is progressive bulbar palsy, which starts with involvement of the bulbar muscles, and the limb symptoms may or may not develop later. There's slow in onset, again between 50 and 70 years of age. The prognosis is poor as people develop difficulty in chewing, talking, and swallowing, and show a reduced gag reflex, a weak palatal movement, fasciculations of the tongue, and weak movements of the facial muscles and tongue, and are at great risk for aspiration, which usually is the cause of death in these people. Some percentage of these people progress to develop full-fledged features of ALS, but some only have symptoms involving the bulbar muscle. Now, how do we diagnose ALS? It's primarily a clinical diagnosis. There's sensory and motor conduction, nerve conduction studies are carried out. The sensory conductions are normal, and EMG is basically diagnostic, though the diagnosis is made mainly clinically, and the EMG would support the clinical diagnosis. There is a well-laid diagnostic criteria which is followed, and one has to be completely sure before offering this diagnosis to the patient. Treatment-wise, riluzole is the only currently available medication for the treatment of ALS. It's a glutamate inhibitor and prolongs life by not more than 3 to 6 months. And this has to be made clear to patients. Usual dose is 50 milligrams twice a day. There are lots of clinical trials on other medication being carried out at the moment, but for the moment, this is the only medication, and it's only used in the amyotrophic lateral sclerosis form of MND. A lot of supportive care is needed. Patients may need non-invasive ventilation or even invasive ventilation depending on their condition, and a cough assist device, which could be helpful. They usually need a PEG tube for feeding. Speech devices are helpful for them to communicate, and supportive care from rehabilitation medicine, occupational therapy, physiotherapy is extremely helpful to these patients. Thank you.